Hello, everybody, and welcome to this Synopsys Simpleware webinar. We're very excited today to present the Hip Detectives, Improving Clinical Outcomes by Leveraging Patient-Specific Orthopedic Surgical Planning. Today we're very excited to have some of our colleagues from the University College London and the Royal National Orthopedics Hospital presenting on some of the work that they do in improving clinical outcomes of their patients. So I will start off by introducing our panelists, and then we'll get going with the presentation. So Professor Alistair Hart is the UCL Chair of Orthopedics and Consultant Hip Surgeon. He leads a research team of surgical technologists based at the UCL Stanmore campus and RNOH NHS Trust, focused on implant science and surgical imaging technology. With running for science being the key project. Alistair has pioneered the use of 3D printing for hip surgery, robotic surgery, and the analysis of orthopedic implants. His research on implant science has led to changes to international health policy, development of clinical guidance in the UK and abroad, changes to clinical practice, and subsequent cost savings. Dr. Johan Henkel is an orthopedic surgeon with research interests in developing imaging software solutions to aid the understanding of the biomechanics of the lower limb musculoskeletal system. His research includes surgical technology applied to hip, knee, and joint replacement, and with expertise in the field of robotics and computer-assisted surgery. And Dr. Anna DeLaura is an orthopedic engineer with a background in biomedical engineering. She is the RNOH Implant Imaging Fellow and Honorary Associate Professor at UCL. Her current research is aimed at a better understanding through medical image computing, surgical planning and outcome assessment, how to improve hip functions in patients with hip problems and hip replacements. She works daily with orthopedic surgeons, engineers, and healthcare practitioners, and is responsible for the development and execution of software analysis for imaging studies of joint disease and reconstruction. So welcome to our guests. With me is my colleague, Ross Cotton. Dr. Ross Cotton joined Simpleware back in 2008 after receiving his PhD in sports engineering from Loughborough University. The research combined experimental tests and numerical simulations to investigate the mechanics of soccer ball impact or football ball impact. The results were used towards the development of the 2008 European Championship match ball. In his current position at Synopsys, he oversees the AE team, focused on technical support and training and delivering service projects and really helping our team out on the technical side. So Ross is a very valued member of the Simpleware team. My name is Karim Gench. I'm the business development manager at Simpleware. My background is that I did my PhD in biomedical engineering, focusing on hip bone fracture mechanics. With that, I'll get started with the presentation. Here, let me just advance the slide here. So this is kind of the inspiration for this group coming together is the Hip Detective book that will be released by Professor Alistair Hart, and we'll get into more details about this book, its inspiration, its usefulness. I've got my own copy here, and it's been great, a nice read, and just kind of a nice way to see how solutions that we provide are actually applied clinically. We kind of get detected into our own little deflected into our own little silos. So it's really nice to see where this technology can be useful. So just some logistics here. This is a presentation with a Q&A afterwards. So or a brief presentation. We'll have some questions for our panelists from Ross and I, and we'll also be taking questions from the audience. So you can submit your Q&A on the right here, and we'll select some questions to be answered live. If we can't get to your question, we'll follow up by email. So if there's any problems, please report these in the Q&A toolbox. So just to give you a very brief background of Synopsys, we're a company based out of Silicon Valley in Mountain View, about $4 billion in revenue now, at least projected for this year, about 15,000 employees, mostly focused in the semiconductor industry. But what Simpleware has offered, Simpleware was acquired by Synopsys about 5 years ago because of our underlying technology. We're very good at handling very messy geometries and structures, like you'll see from patient data, where it can be very organic shapes within the 3D CAD world. So we offer that kind of technology that is very useful in different applications within Synopsys. So about the Simpleware product group itself, we develop a high-end 3D image processing software. So image to model, that's the higher the 50,000-foot view of what we do and enabling that process for our customers. So we have sales, support, and services teams around the world with a global presence, and we work with customers in clinical, life sciences, such as within this webinar, but also in more materials and manufacturing area as well. But our main focus is definitely the life sciences. So with that, I'll pass over to my colleague Ross to get us into a little bit more detail about Simpleware itself.
Great, thanks, Grim. Great to be presenting today on and I'm going to give you a brief overview of what the software does. So our software solution is a complete 3D image processing platform. As Grim mentioned, it goes from any type of 3D image volume through to a 3D model and everything in between. You can see a glimpse of the user interface on the left there, ribbon design, and we'll go into some of the benefits in the next slide. But in terms of what we can do, we can import a wide range of imaging formats, obviously DICOM, and with our medical version, you can connect to PACS. The medical versions also has the FDA clearance and the CE marking. So 3D, 4D image support that comes in. We can a range of visualization tools, including an animations toolbox if you want to rotate and spin around or fly through models, surface rendering, volume rendering. And then from there, we kind of maybe move into segmentation and processing. So we have a really nice suite of user-friendly segmentation and image processing filters to get the most out of your image data as quickly as possible. This has been recently supplemented by our new AI segmentation, AS Ortho and AS Cardio, where we can use machine learned models to automatically process, segment and landmark certain anatomies in different modalities across the body. From here, we can then take measurements and analysis, so things like fitting center lines and volume surface areas and fitting shapes, for example, is another key component. And then the image exports, some model exports, so not just the animations, but you can export simulation-ready models for finite elements and CFD analysis. You can also go to 3D printing, STL, 3MF files. Recently added a 3D printing toolkit to even further simplify that workflow. So you can do all your kind of prep of adding supports or connectors and other kind of 3D printable features onto your models. And that's supplemented also by the scripting. So as you become more familiar with the software, you can start automating repeatable operations with the Python scripting. So why use Simpleware? We believe it's easy to learn and use. So for a beginner, you can pick it up, you can start processing data. We have a lot of help and tutorial guides to get you started. Fast and accurate, definitely accurate on the accurate side. We do a lot of work on that area to ensure what you segment is what you get out in your final model. So no defeaturing, simplification, and so on. Very powerful, reliable, but it can be run on very standard laptops. So even the AI tools can be run on laptops, or you can scale that up onto a cloud deployment if you wish. Pretty customizable. So not only is it good for new users who have maybe little experience, but you can also, once you become more familiar, really start to customize the software through the scripting and plugins and calling it from maybe other packages or programs. Fully supported, as I mentioned, the help guide. We also have the support team, mostly based in the UK and also in the US, to answer any questions, big or small. And next slide, please. And as we mentioned, we deal mostly in the life sciences and clinical applications. Here's just some of the areas we get involved with, and that leads us nicely into today's talks, which will be on implants, guides, pre-surgical planning. And next slide, please. And in this area, this will lead us nicely into Anna's talk. So based on preoperative scans, 3D, CT, or MRI scans, you can then start to look at guide designs, surgical planning, 3D printing, and so on. And I won't say too much more on this. I'll leave this to the experts to talk more about this. And I'll now hand over to Anna to talk you through a bit more about the research and work. So should be now presented, Anna.
Thank you very much. Thank you, everybody. Hello, everybody, and great to be presenting today. I'm going to talk about three-dimensional CT surgical planning in knee replacement, from patient imaging to outcome assessment. I'll share a detective story, a true story extracted from the book to guide you through the workflow of surgical planning in primary hip replacement, and then go through the complex revision surgery. I'll show you how we measure surgical outcome, and I'll go through the current unmet needs or challenges in hip replacement. So the surgical plan, it all starts with patient imaging, the protocol. Computer tomography is key for the analysis of the bone morphology, for anatomical review, planning of implant sizing, planning guides, restoration of patients' biomechanics, central rotation, leg length. So the detective story. So Alex, as a male patient, presented pain in his right hip. The pain was impacting on his life. He had previously undergone spinal fusion, L3-5, and scoliosis correction. EOS standing and sitting imaging was used to help understand leg alignment in a functional position. The sitting image, it was used to assess the spinal pelvic alignment. So the evidence, AV X-ray demonstrated end-stage osteoarthritis of the right hip with a loss of joint space. So CT imaging was used to plan the procedure in terms of optimal component size and orientation, as well as design patient-specific instrumentation, femoral neck cut and reaming of the acetabulum. Bone quality is assessed, and it's important also for screw fixation. So the outcome, EOS imaging, standing EOS demonstrated no evidence of leg length discrepancy after the procedure. EOS sitting showed abscess of impingement between the cup and the stem. So the verdict was that previous spine surgery is a risk factor for dislocation of a hip replacement. Optimal positioning of acetabular and femoral components is crucial, and therefore patient-specific plan is more important in this group of patients. So through the analysis of outcome assessment with Synopsys and Simpleware software ScanIP, we've been able to identify an unmet need in CT planning. So the planning and delivering of the orientation of the femoral component in uncemented fixation. So co-registration of imaging, sequential imaging, but also comparing the plan and what was achieved after that procedure, allows us to analyze new tools, aid planning, and gives us data to help develop solutions. Now, compared to primary revision surgery, is more challenging to plan and execute. It often involves the management of a large acetabular bone loss, a potential indication for the use of custom-made implants. The appreciation of the bony defects is crucial, especially in implant designing. However, there are issues, challenges in this field. So poor visualization of the bone due to metal artifacts, preventing accurate design of the custom implant, as well as bone removed revision. So we studied use of a two-stage procedure for the reconstruction of large acetabular defects to understand to what extent bone information obscured due to metal artifacts can affect the design of customized implants. We compared scans taken in pre and post implant removal and found that bone shape changed in all cases. This is of clinical significance as it leads to implant design modifications, and it may ultimately change the surgical procedure and instruments needed. So ScanIP, particularly AS Ortho, allows to segment bony anatomy, which is in presence of the metal environment, in an effective and fast way. And this provides a solid basis for bony morphology assessment in a metallic environment. Other challenges linked with the use of CT scanning are the narrow field of view and the patient, and the fact that the patient is in a supine position, so not in a functional position. Leg length is extrapolated from CT scan. with the surrogate measures such as vertical femoral offset, which is the vertical distance between the central rotation and the lesser trochanter. Pelvic measurements constitute a surrogate for leg length, but this can lead to significant limitations because we're not taking into account other causes of leg length discrepancy, including abnormal pelvic orientation, bone-leg inequality, fixed flexion, and asymmetrical femoral and tibial torsion. So the ideal plan would involve the registration of image modalities such as CT EOS by biplanar orthogonal weight-bearing radiography is key for the functional reconstruction of the pelvis. And you can see here the registration between these two modalities in ScanIP. And understanding bone quality is essential for the design of an implant and its positioning into the best quality bone. And this also guides screw positioning. And here we are measuring if we've achieved the plan. ScanIP, we can study the implant orientation in 6 degrees of freedom, analyze, plan, and achieved. And this is also essential for after measure, but also for the study of implant migration over time. And this was an overview, and hopefully we can expand on the slides. Thank you.
All right. Well, thank you, Anna. Yeah, it was great to see that presentation of some of the work that you guys are doing within your lab. So what I'd like to do is get into some questions for this panel, and just to remind folks, I think this is a rare opportunity. We have everything from Anna being the core researcher, Johan being the orthopedic surgeon researcher, and Professor Alistair Hart being primarily the surgeon. So we have the full spectrum here, and it's rare to see such great collaboration from research all the way to clinical applications within a single lab. So so we're very excited about this. But I think I just really wanted to start off, Professor Hart. I've got a question for you about what really inspired this book, The Hip Detective, and where'd you get your inspiration for this?
Well, many thanks for taking an interest in my team and the work we've done and this book. The inspiration has come from patients that are featured in the book and the surgeons that we've taught using the material within the book. It represents my journey in hip surgery over the last 20 years. I started doing hip surgery in 2000 as a trainee and then became a consultant in 2006, and slowly did more and more complicated cases and took an interest in technology at an early stage. And with Anna and Johan, we set up courses for surgeons, and we used cases and the technology that we used for each case to describe a ladder of reconstruction that hopefully brings the cases in the book together in a logical way that it's easy to learn.
Great, thank you. Thanks for that introduction to the book, Alistair. I've got a second question here, so maybe to both Alistair and Johan this time. When and how did you start using CT image data to plan orthopedic surgeries? Maybe to Professor Hart first.
So it was, of the two of us, it was actually Johan that started using it first. But I'm sure he'll tell us about that. I started using it in 2006 with the Acrobot robot, which was a CT-based system, so required the CT scan to plan and create the computer models to work off in surgery. I used patient-specific instrumented guides for knee replacement from about 2014. And then about 6 years ago, with Lima, we started addressing the complex and very large acetabular defects that Anna's introduced you to some of them. With Medacta, we've then extended this to primary surgery using CT planning and patient-specific instruments for the hip. I'm a hip surgeon, and generally hip surgery has lagged behind knee replacement in the adoption of CT planning, the adoption of navigation, patient-specific implants, and also robots. But hopefully we're not far behind, and I think it has a great growth for hip surgery in the future.
Thank you. Maybe over to Johan next.
Yeah, I started using this when I was pursuing some research, sort of PhD research in robotics way back in 2004, 2005. I think in the lead up to the robot Alistair eventually used and spoke about, we were of course trying to define a plan. So using an image-based system to plan surgery and to inform the robot as to what to do. And so that's when we started. And the initial challenge at the time was sort of segmenting and getting a true representation of the patient's need in order to match with the robot for surgery. So that was the early start. CT scanners were not as sophisticated as they are now. The slides, now we have 64, 128, 256 scanners. There were sort of 4 slide scanners, 50 slide scanners at the time. So that evolved. So that was back then. And segmentation was line by line of the pen going around each slice to generate a 3D model, and things have moved on tremendously with the scan IP and simpleware. So that was the initial journey, and then we moved from the hip to the knee with a navigation system and all image-based. So in the use of an image-based system, you need to have the patient's model to guide the tool. So that was sort of the second step. And as I said, we then moved on to use it to develop patient-specific instrumentation. And I think eventually, and more importantly, the use of CT scanning to measure the outcome of these smart tools that we're innovating and developing. And I think that's one of the bits that has been sort of missed out in the use of 3D imaging, is that we are bringing tools to market, but testing and understanding and measuring the outcome of these tools, again, 3D, CT, 3D imaging is crucial.
As kind of a follow-on to that, Johan, when did you start seeing the clinical improvements and seeing, the application of this new technology, actually improving the results from your patients? Was it immediate? Was it a slow scale up, or how was it?
It's a good question. I think in looking at patient outcome, there's the radiological or the structural outcome, and there's of course the clinical outcome, and that takes time to measure. It takes a very long time to assess, has this innovation, has this implant or this technology made a difference to the patient? What we found early on was that we were able to deliver the plan, and we did studies to compare plan versus achieved, plan versus built. And the imaging was very helpful in showing, yes, we've taken the plan to the patient and delivered it. And so from radiological outcome, we're able to show that right.
And so I guess
so
there
are two bits to the answer that Johan's given you, Kerem. One is immediate, and the other is evidence based to then prove to others the benefit of it. But there is no question the first time you do CT based navigated or PSI or robotic surgery that you realize that this works as a positioning technology. Then you have to decide which do you get on with best and how much hassle are they to actually implement.
Okay. I mean, so kind of moving more towards the research side, maybe this is a question for Anna. Where, now that you see some of the results, the improvements, but of course on the research side, I'm sure there's always more questions, gaps in what you see. So I guess that's kind of a general question of where do you see the biggest gaps currently, or what are the biggest questions that you are, as a researcher trying to tackle from a general sense in this area?
Everything that we do in terms of research comes from a clinical question, and therefore from the work that Prof does with his patients and Johan, of course. I think that the orthopedics is moving, as well as medicine in general, is moving towards a more targeted, personalized approach. And we are, with improvement in image modalities and the availability of software which we can do analysis with, and as well as we can actually plan and use different image modalities to assess spinal pelvic relationship, for example. This is a concept that for hip surgeons maybe it's recent. So I think it comes from the clinical needs of course, Prof's patients and Johan's patients. I think the unmet need is we still need to work towards being able to, for example, segment in a metallic environment and being confident of that we are actually extrapolating the true anatomy, and this is one of the challenges that I see in everyday life, and of course demonstrating that even for primaries, the surgical plan is very, very important, and it's actually the new tools are working in delivering the plan. So showing that in a scientific way, that is very important, and of course that has challenges, but it's important in delivering the message that new technologies are aiding the surgeon and helping the patients.
I think that kind of does lead us nicely into the next question. I think you touched upon the challenges of working with revision and primary, well, mostly revision cases there. Maybe to the whole panel. Obviously, segmentation is a big challenge. Are there any other challenges, or do you want to elaborate a bit more on the segmentation of revision cases, and is that the biggest challenge in planning revision cases? Maybe, yeah, Alice, do you want to maybe start?
So I get a CT on every revision case that I do. And at the moment, it's the manufacturers that are segmenting and planning the cases, or at least suggesting the first plan to me. It reveals whether we can use a certain type of implant. For example, do we need a complicated stem with multiple ways of adjusting it? What size, what offsets do we need? And some of these stems are incredibly complicated with many different combinations of modular components. It enables us to share images amongst ourselves and figure out whether reconstruction is possible or not. So that's in terms of revision surgery, and Anna's alluded to the problem of metal artifact reduction. I don't get too involved in the actual software functionality. I'm hoping to leave that up to you guys, and you certainly seem to be doing an extremely good job of that. And I think working with the manufacturers, you provide fantastic possibilities to surgeons like me.
Thank you.
Coming back to generating the image, in revision surgery, as Anne said, and as Alistair just mentioned, the metal artifact is a huge deal. Every revision case, almost every revision case, has indwelling metal. And at the moment, there isn't any sort of robotic system, image-based robotic system that can aid surgery because of metal artifact. Generating a surface for co-registration for robotics now currently is not possible. Coming to why are we doing it and what are the issues? You want to size the implant, you want to evaluate the bone stock, you want to see what is viable. And that bone implant interface is a big deal. Anna has done some work looking at a series of cases where we did an interval scan. So between taking the implants out and actually putting new implants, revising the surgery, a scan was taken. And we're able to evaluate the impact of this metal. These are patients, these are real patients. We're trying to get implants to fit them. We're trying to understand the bone. And we see this huge gap. It is a big gap. And learning to understand the ones we can get away with, or the ones we recommend, an interval CT scan, and also knowing the limitations of what can be done with that scan. So I think that's the primary hurdle, I think, with imaging. Of course, you can make gross measurements. You can sort of measure the intimate space. You can measure the defect, but getting things to fit that space, we need a lot more information. And then moving into the level of sort of patient-specific instruments. So image-based planning for these instruments. Again, challenges with the CT scan, the quality of the scan is a big deal.
Mm-hmm. Okay. So shifting a little bit to more, to the use of 3D printing at the point of care. That's been something, especially here. Obviously in the U.S., they're called CPT codes, the insurance reimbursement codes, are just starting to be evaluated, and it's starting to be more widely accepted as a way of helping surgeons plan patient education, teaching. So for your case, how have you and your lab integrated 3D printing into your orthopedic surgery practice? So I guess we'll start with you, Alistair, again, and then move down the line.
Well, the manufacturers have been very good to us. They create really very accurate models. We know they're accurate because we've been inside these patients and we've done it many times. So, for example, in this patient, the size of the defect, so the femoral head is filling very little of this acetabular defect. So this is life size. This is a very complicated 3D problem that a 3D printed implant solved for this lady. She liked shoes, and every single pair of shoes had to be built up by this much, and she had to walk with crutches. Her life was really very difficult indeed. Now she walks unaided. It's about 3 years since we did this one, and the only downside is that she's had to buy a whole load of new shoes without the step up. But this is a complicated 3D problem. It's a no-brainer that you need a 3D printed model before you start trying to tackle this. This is a long operation, at least 3 hours. You want to be able to do your homework before. You want to know the size of the defect. You want to know the anatomy. You want to try to work out how to expose the anatomy, particularly if you're keeping the stem. If you're keeping the stem, you want to know how much you're bringing down the center of rotation to determine whether she's going to have equal leg length after the operation. So 3D models for complicated 3D problems are a totally obvious step. Implementing that step as point of care, so within a hospital, is the next really obvious step. And I think there are some hurdles on the way. You know, how do you make sure that the models are accurate? But at the moment, surgeons are looking at 2D screens, sometimes with 3D CT images, but of course those are 2D snapshots. And what they really need is a 3D model.
Thank you. Yeah.
How are we bringing it to our practice? So I think the points Alistair made are really appropriate here. But how do we bring it in-house? I think to sort of make it a lot more available, user-friendly, improve turnaround time, etc. I think it comes back for the primary, say you've got a complex primary. I think it's relatively straightforward. Your segmentation software generates a 3D model and you push to print. I think that's something that's very doable. You've got to think about the costs in an English sort of British NHS system. How do you make that affordable? How do you make a business case for it? We have started looking from a research perspective, trying to evaluate the benefits and look at the radiological outcome of just sort of a print, having an accurate 3D print of the patient. And the issues, again, we mentioned about artifacts. So we've got automated solutions that you guys now offer. AI sort of offers for us to segment and do it in-house. Anna leads a team of students that aid that process. Here's an interesting example. We've been doing some prints with a printer that actually reveals bone density. And we take this model into the operating theatre and aids the surgeon understanding where is the dense bone, where can you put your screws, and how can you aid surgeons. So I think we're getting there. Getting engineers on board in a hospital scenario to do this. Getting to point of care for the surgeon, getting the surgeon to do the segmentation, to do the printing. I think that's another step. And I think having software solutions that are available to the surgeon to user-friendly enough, I think we are a little bit away from there. But we're beginning to demonstrate the benefit, and I think some of the younger members of the team will begin to do this more and more.
I think I'd say one more thing actually. If it does become point of care, then the patients are going to really appreciate it. It is such a useful tool to explain to patients what you're going to do to them, and it gives them a lot of confidence that you know what you're doing, that you've done your homework, and that you've thoroughly looked at their problem as well as you can.
Definitely. I mean, I'm in agreement, and yeah, we definitely seeing you know, Prof. and Johan wanting more and more of these models because they actually are tangible way to interrogate the anatomy before going to theatre, and also during surgery to appreciate how this, you know, the implant has been put in, and having a reference is important, because what the engineers see when they plan is the anatomy, is the whole pelvis or the whole femur, the bone. But the surgical incision allows the surgeon to only see a very small amount of that bone that is possible to see amongst other tissues around it.
Yeah, it's really exciting to see the use of color as well, because you know sometimes when color is introduced, you're not sure how useful clinically it can be, but it's nice to see that there's interest in mapping bone density and really understanding, having that as a guide to help with surgical planning is very nice, especially there's the RISE printer, that we have the J5 MediJet printer from Stratasys. Both we have FDA cleared. So we're excited to see people use this in clinical practices and see where we can take it. I mean, we're the tool builders. You guys are the workers and the applicant people applying them. So it's always nice to see these.
There's something I quite like to chip in here with. So particularly if you've got lots of engineers on the call or non-clinical people. So it's really easy to do an operation on this. it's really easy to get it exactly right. There's no blood in the way. There's no fat. There's no femur that I have to move out of the way. I don't have to worry about cutting any nerves or blood vessels, or even sticking a screw into the colon. So you just have to be a bit careful that there's a lot of real life that you need to consider around this. And in particular, when you get sent plans from engineers, they give you screws that are really quite long, and they might have trajectories that you're just not going to be able to achieve because you've got a patient wrapped around this point of care printed model.
Actually, as you're saying that, I just saw a question come in that I think is very relevant, and I'd like Ross for you to address it. Is the one question was, for the clinical perspective, is it important to compensate for the partial volume effect when the cortex is thin? So this fits perfectly with the new tool that we just released that Johan and his group has been using. Ross, I don't know if you want to explain how we map the color in the Hounsfield units to these surfaces.
Yeah, sure. Obviously, this was done obviously in collaboration with Johan and Anna, and getting around the partial volume effect. What we do for this new tool is in the 3D printing toolkit, actually, so it's kind of easy to find. Once you get your model ready, we apply this analysis, and what it does is for every point on the surface, we go inwards a certain depth, say 4 millimeters, and then we can take, say, an average of the Hounsfield units across that depth. It can also be the max or minimum perhaps as well for other variations, but this kind of negates the partial volume effect, and you can get not just kind of bone quality, but bone density as well. And that's the kind of coloring you see. So the more red it is on the model, the thicker and denser the bone. Because on the surface you could get very thin cortical, and it would look the same as very thick cortical. So this depth information gives hopefully some very clinical, useful information. And I don't know, maybe Johan, you want to comment a bit further from your perspective on the colouring?
I think we've been evaluating it, because I mean, here's the new technology, here's the new application, here is we are sort of getting a lot more data out of the CT scan. So first of all, we start just looking at 2D slices. A lot of analysis was based around a 2D slice. We then learned to stack it up, and we've got a 3D model, external looking model. Now we're sort of using the Hounsfield threshold to appreciate a bit more about the density of the bone, but also give visual aids to the surgeon. So we're trying to we're generating evidence with the use of these models. We are also using different levels of thickness to understand, you know, how far can you put the screw? What's the thickness of that density of bone? What's the change across that volume or that shape or that distance? So it's early days. We've done a few cases. We've taken the models into theatre. We've looked to identify more robust bone, more tough bone. Interesting. We hope to have something published at some point, but we're gathering data from it.
Mm-hmm. Yeah, and actually, the same person followed up. Is there a scientific rationale for the 4 millimeter? And currently, there isn't. This is a new tool, and that's why we're putting it in the hands of our customers to figure that out, to figure out what is appropriate. You know, should it be uniform? Should we have a way of mapping different depths of different areas? Also, this extends, you know, I'm curious to see, my background, I did, you know, computational modeling, and that was an issue, is when you map the grayscale values on the surface, because of the partial volume effect, you get, the cortical bone gets a reduced material property. It becomes artificially, I guess you can say, soft, for lack of a better term. And having this kind of way to compensate for that could have helped. So it's an interesting tool. We're curious to see where our customers take it and the feedback we get. So for anybody who wants to explore it, we're definitely open for feedback to understand how better to apply it to different applications.
Yeah, so user specified value. So we'll just plug 4 millimeters out the air, but you can set it to whatever value you would wish for in the software.
Yeah, we've been trying 1 millimeter, 1 centimeter, 15 millimeters. We've been using different thresholds to evaluate it. Yeah, so 4 millimeters was a start, just to sort of set parameters, but we've been expanding it and getting some understanding of the nature of the bone. And of course, there's the added problem of thresholding using the grayscale again, where there's metal or metal artifact. So finding strategies around that, again, a challenge.
I'll just take another question from the audience. What financial impact does this technique have on the whole replacement process? And what are the goals of making it more accessible / cheaper for patients / surgeons all around the world? I guess this is definitely a broader context of this.
Yeah, so I'll have a go at that. So these implants, these are 3D printed implants. They cost £17,000, and this one fitted in that hole in that story that I described to you earlier. And the case, if you want to see the case, it is in the book here, and so on. So £17,000 worth of cup cage. Within this goes a dual mobility bearing, and then there's also the head and the stem and so on. So it's definitely £20,000 worth of implant in that patient. So the business case for really complicated work is, I think, very easy to make. Who's going to put their hand up to actually pay for it is being developed, but it seems to make sense that the manufacturers of the implant also invest in making the models, and in also invest in making 3D printed instruments to position the implants. They are going to get ahead. They are going to get their implants sold, and presumably they just simply add the cost of the printing to the cost of the implant. At the moment, I hope that 3D printed implants for complex situations are going to be much cheaper than £17,000 as technology develops, but it's not been going that long. In short, it's going to be the manufacturers.
Good. I guess, Ross, I think we have probably time for one last question for our panel here.
Yeah, should we, I think, take the other one from the audience again, I think?
Sure.
Yeah, I've got a question from the audience, very interesting one. It sounds like they're due to have hip surgery soon. And the question is, are we now seeing leg length discrepancies becoming 100% successful?
Johan, what do you think?
I think one of the main sort of complications of hip surgery, of course, is leg length inequality. I think with these tools now, we are really reducing that, particularly with the use of PSI. So this morning we were looking at quantifying the level of neck cut with patient-specific jigs made by one of the companies we work with. So I think that and this may be being too much of an evangelist, but I think almost every CT, every hip replacement should really be done planned and precisely planned. Okay, the cost, of course, you've got to think about the cost of CT scan, the cost of technology, but if your hip can last 5 years longer or 10 years longer, I think your prosthetic hip lasts 10, 15 years longer. I think it's a win-win. So I think, yes, of course, you need a well-trained surgeon, you need the best. Success is multifactorial in any procedure. You need to get the implants right, you need to get the plans right, you need to get the surgical tools right, and you need to choose the right operation for the patient. But I think with the current technology, I think leg length discrepancy is yesterday's problem.
So leg length discrepancy, 100%, I'm going to say no. Any doctor that says 100%, you need to be very careful with. Now, 99% or 98% or 97%, now we're talking. And of course, in patients with really complicated problems where the leg length discrepancy is really quite large to start with, then I think without a CT plan, you're inviting disaster. It's interesting that of all the issues that you brought up, and whoever that person in the audience brought up, that's a very pertinent one, because that patients know immediately they wake up whether one leg is longer or shorter than the other. They do not know when they wake up the cup position, whether it is optimal or not. But leg length is a really, really important one. Good topic.
All right. Great. Well, I think we're out of questions here, but I'd just like to do one last thing and go across the panel and just, 2-3 sentences, what is the future of CT-based patient-specific surgical planning? And what are the, we'll leave it at that, yeah.
I'm going to continue where I left off from really. I think every patient should have a CT-based planned hip replacement. Of course, younger patients, I think it's a must. Complex anatomy, a must. And I think there will be a move towards it being essential for everyone. I think the cost of CT scans is coming down. The cost of this technology is coming down. I think we'll get there. So I think the future is have a 3D CT plan or a 3D plan of your surgery before you proceed.
I would say yes, definitely wider adoption of the technology.
Yeah, I'd say that the future for CT planning is huge. I would start from the opposite end to Johan, and I would say the case is very easy to make for really complicated surgery. Will it be used for every single primary operation? That's a very good question. For the ones in between, so the complicated primary surgery, I think there's an extremely good case for that. If you look at Mako, they need CT to use the robot, and that is being used for primary surgery. In fact, it's not allowed to be used for revision or complex hip surgery. So they've already made the call that CT planning is 100% necessary for primary surgery. I think for much wider adoption, I think it might come, but I would predict that 50% of hips within the next 10 years could be CT planned.
Okay. All right. With that, I think I'd like to thank our panelists for joining us today and presenting. Thank you, Ross, for joining me on this. So with everybody who attended, I'd like to thank you as well. I think we got to pretty much all the questions. If not, we'll get back to you via email, and also you will be sent a link of the recording of this webinar. So thank you, and take care, everybody.
Thank you. Bye.
Thank you. Bye.
Bye.
Are we